So I'm Jenny Sprague. I am a pediatric endocrinologist at St. Louis Children's, and I'm talking to you today about pediatric obesity. I do have two disclosures. I'm a site investigator for two different industry-sponsored studies, one from Rhythm Pharmaceuticals and one from Eli Lilly. Both drugs are for treatment of obesity, one also for diabetes. I will touch on the drug from Rhythm Pharmaceuticals, setmelanotide, but I was not involved in the study that's discussed here. So the objectives today are to recognize that the complex factors that contribute to development of pediatric obesity, understand that obesity is a complex chronic disease requiring a multidisciplinary treatment, identify pediatric patients with obesity who are at risk for multiple comorbidities, and describe treatment strategies for pediatric obesity. So we're going to start with a case. So this is a patient who presented in January of 2017. At that point in time, she was a 12-year-old who came in with polyuria and polydipsia. She had a 22-pound, what she thought was an intentional weight loss, though in retrospect, it was likely influenced by her new diagnosis of diabetes. Her PCP ordered baseline labs that showed a random glucose level of 300 and a hemoglobin A1C of 10%. Her exam was really notable for obesity. Her current weight at presentation was 127 kilos, so 279 pounds at age 12. She did not have acanthosis nigricans on her exam. Additional labs showed negative diabetes antibodies, an elevated ALT level, and she got started on basal bolus insulin as well as metformin. This is her BMI chart at the time that she was diagnosed with diabetes. Her BMI was a little bit above 40 at the time of diagnosis. So let's start first with an obesity definition. This definition comes from the Obesity Medicine Association, and I think it does a really nice job defining the concept of obesity, but we'll talk about practicality in a second. So the definition is a chronic, progressive, relapsing, multifactorial neurobehavioral disease. So it's chronic, it lasts a long time, it's progressive, it often gets worse, it's relapsing, so even if it gets better, it may get worse again. There are many factors, and neurobehavioral components are an important part, wherein an increase in body fat promotes adipose tissue dysfunction, abnormal fat mass physical forces, that results in adverse metabolic, biomechanical, and psychosocial health consequences. This is a really comprehensive definition, but it's not very practical to identify your patients who have this problem. So in general, we use BMI to define obesity in a clinical setting. It's easy to assess, but it may misclassify individuals who have a high fat-free mass or a high muscle mass. You guys are probably all familiar with a BMI curve, just like we use growth curves for height and weight. We use growth curves for BMI. And so definitions for pediatric obesity, normal weight is between the 5th and 85th percentile, overweight between the 85th and 95th percentile, and a BMI greater than the 95th percentile is considered obesity. However, if you remember our patient, she was well above this 95th percentile, and so several years ago, extended BMI growth charts were developed and published for severe obesity, and this allows us to classify obesity similar to what's done in the adult setting as class 1, which is between the 95th and 120% of the 95th percentile, class 2 between 120 and 140, and class 3, or the most severe obesity, is BMI greater than 140% of the 95th percentile. Now, what about prevalence? We are constantly hearing about the increasing prevalence of pediatric obesity. This graph is showing prevalence in youth age 2 to 19 between 1963 and 2018. The data comes from the National Health and Nutrition Examination Survey called NHANES, and you can see there's been a significant increase in prevalence in all age groups after 1980. In adolescents, that's the 12 to 19-year-olds shown in light green. The national obesity prevalence increased from around 5% in 1980 to about 20% in 2018. The second graph subdivides the pediatric obesity prevalence into the classes of obesity. So the bottom two lines show the prevalence of class 2 and class 3 obesity. Both are considered severe obesity. Class 2 increased by 50% between 1999 and 2014. Most concerning, class 3, the most severe, so BMI greater than 140% of the 95th percentile, more than doubled between 1999 and 2014. So that's really rapid increases in the prevalence of obesity. Now, we often think about development of obesity as this simplistic balance between energy intake and energy expenditure. If energy intake is too much and expenditure is not enough, then weight will go up. I want to just introduce the concept of a body weight set point. Things are much more complex than that. So body weight set point comes from adult data showing that if a patient has obesity and they lose weight, there are changes in hormonal regulation, specifically in leptin and in hunger signaling to promote weight regain. So it's not a simplistic, you just cut back on your calories and you will lose weight. This is a chronic relapsing disease. And there are many, many factors involved in the development and the maintenance of obesity. So there are biological factors like the in utero environment and birth weight. So in utero environment may lead to programming of the body. This is called the developmental, it's the Barker hypothesis, the developmental origins of disease. So in utero factors influence long-term outcomes. Birth weight, so patients who are born high birth weight and low birth weight who then have catch-up growth have an increased risk of obesity. There are genetic factors both in susceptibility genes as well as epigenetic modifications related oftentimes to that in utero environment. Ancestral background, gene-gene interactions can influence obesity risk. Then there are environmental factors like food availability, social determinants of health, built environment. So thinking about obesogenic foods, for example, increases in sugar-sweetened beverages, fast food, large portion sizes have all occurred over the same time period that we saw this rise in obesity. It's frightening to think that in the US, between 10 and 15% of total caloric intake for children comes from sugar-sweetened beverages. Grocery store access, fast food access, vending machines in schools, all are things that can contribute to the development and maintenance of obesity. Physical activity is also influenced by screen time associated with less physical activity, decreased screen space also associated with less physical activity. And then behavioral factors, parental factors. So for example, parental feeding style. Multiple studies have shown that an indulgent feeding style is associated with higher energy intake. Parental eating behaviors, stress affect child eating habits. So all these factors playing together to affect both the energy intake, the energy expenditure, and how the body metabolizes the energy that it takes in. Now, we often will also think about those hormonal signaling mechanisms that do regulate energy balance. So we're going to look at some hormones that interact in the brain to regulate energy intake and metabolic rate. So let's first look at leptin. So leptin is secreted by adipose tissue. More adipose tissue makes more leptin. Leptin signals in the arcuate nucleus. This is in the hypothalamus on receptors on neurons called POMC. And POMC neurons decrease hunger. They are anorexigenic. So signaling through here will decrease hunger. If we look at ghrelin, ghrelin is secreted by the stomach in times of fasting. It signals on adjacent neurons called neuropeptide Y, or a Goody-related protein, and those are orexigenic. They increase hunger. And there is this interplay of these signals in the brain to increase hunger or decrease hunger, depending on fasting state, relative degree of obesity, and sometimes there are mutations or problems within these signaling pathways that can lead to increased obesity. These also will eventually be our targets for pharmacologic treatment of obesity. Here I'm going to take a little bit of sidestep because in our pediatric obesity guidelines that were released in January of 2023, this is the first time we've had pediatric obesity guidelines. There was a lot of emphasis on health disparities and health equity, and this really hasn't been discussed that much in previous publications related to the treatment of obesity. So I'm pointing this out. Many people have probably seen a graphic similar to this where we're reaching for health equity by reducing disparities, but I want to point out that disparities defines the differences between groups, but it does not refer to the inequities that cause the differences. It's important to distinguish because the risk factors for the inequities or for the disparities are embedded within the society that these kids have to live in, the environment that they live in, and there's a danger of stigmatizing children based on their race, ethnicity, gender, on the disparities of outcome without recognizing the systematic challenges that cause and maintain inequities. And so there's a section within these guidelines specifically on racism and obesity, defining racism as a system of structuring opportunity and assigning value based on social interpretation of how one looks, that's race, that unfairly disadvantages some and unfairly advantages others, and that impacts the health status of children, adolescents, and emerging adults and their families. So this is going to get to the social determinants of health, and there are multiple that are linked to obesity. So poverty, unemployment, lack of home ownership are all factors that are linked to increased risk of obesity. This map is showing St. Louis, and this is a side-by-side comparison of historic redline districts. So redlining was banks rating neighborhoods as declining and not desirable, and so refusing to give loans to people wanting to live or work in those areas. And the highest areas of redlining are seen in red, and then the next highest are seen in yellow. And then side by side with that is a 2018 map of social vulnerability quartiles. So this is thinking about those social determinants of health, the economic stability, education access and quality, neighborhood and built environment, social and community context. And so the darker the purple color, the higher the social vulnerability, the less supportive of and stable of a neighborhood. And you can see, sadly, there's a pretty close visual correlation between the red and yellow in the redlining map and the higher social vulnerability in the more modern map. So what we did in the past influences what our patients have available to them now. And that's relevant because there are studies showing that children whose parents have lower levels of education have a higher odds of having obesity compared to children whose parents had higher education. And children whose parents had lower socioeconomic status, for every 1 point increase in socioeconomic status, there was a 1.17 point increase in the prevalence of obesity. So lower socioeconomic status, higher prevalence of obesity. So one of the things these guidelines ask us to do is to screen for food insecurity. And this is sort of a little bit counterintuitive in some ways, because you might think about food insecurity meaning lack of access and so lack of food, but oftentimes it means that the food is just not going to provide the nutrition, but it'll still provide the calories. So food insecurity is common. It's at least 1 in 7 children. After COVID-19, it's maybe as many as 1 in 4 children. And it's associated with worse health status, developmental risks, mental health problems. But from a nutrition perspective, it can lead to diet monotony and decreased nutrition quality. So fast food, quick things that you don't have to cook. If you don't have a kitchen, you can't cook real food. So those things are going to be associated with higher risk of obesity. The screen that's recommended for food insecurity is the Hunger Vital Sign. It's a pretty quick and easy questionnaire. It's only 2 questions. And there, within the past 12 months, we worried whether our food would run out before we got the money to buy more. And within the past 12 months, the food we bought just didn't last, and we didn't have money to get more. It's answered as often, sometimes, never, or patients can refuse. So it's very quick. We've incorporated it into our review of systems forms that all patients get. So we now screen all of our weight patients, but also all of our diabetes and endocrine patients. And for those of you who use Epic, this is available to chart within Epic, within the history tab, these hunger vital sign questions are there. Now, once you identify it, you probably want to be able to do something, right? So the resource I most frequently use is the St. Louis Area Food Bank has a zip code search function that you can make available to patients, and they can search for food pantries in their area. It doesn't solve all the problems, but at least it gives you some resource to help these patients find access to food so that they can work on improving their nutrition. Okay, so now let's think about weight stigma and their health consequences. There's many negative stereotypes attributed to individuals with high weight. So even though we've had advocacy and protections against discrimination, other things like race, gender, and conditions like HIV, we have not made that much progress in addressing weight stigma. People with obesity are often characterized as lazy, not intelligent, not successful. The disease of obesity might be attributed to lack of willpower or lack of self-discipline or non-compliance with their treatment. And many of these statements are made with the belief on the person making them that that negative stigma is going to be motivating to the patients who have obesity to make healthier choices. However, we know from other disorders and from the study of obesity that stigma is not motivating. Instead, it usually worsens health consequences. Those experiencing weight stigma are more likely to have unhealthy eating behaviors, lower physical activity, psychological disorders. They may receive substandard care. They may not have screening for conditions that are recommended, or they may have all of their complaints attributed to their obesity, and they may have decreased healthcare utilization. They feel stigmatized and they don't want to seek out care. In addition, it may increase their risk of bullying and often leads to obesity not being treated as a disease. Social stigma also has a public health consequence. So acceptance of weight stigma legitimizes the bullying about weight. Obesity is not viewed as a disease, it's viewed as a weakness, so it's not treated as a disease. And more broadly, that means ascribing poor choices and weakness to be the cause of obesity allows us to ignore the genetic, social, and environmental factors that promote obesity. Obesity as a personal responsibility will mean less focus on public health prevention, like changing the built environment, food accessibility, that has decreased walkability, physical activity associated with daily work. So we need to focus on all of these factors and address these social inequalities. When we take all of this weight stigma together, what that really means is greater morbidity and mortality for patients who do have obesity. And this is a population health consequence, not just an individual health consequence. Sadly, healthcare is often a source of weight bias. So we have two types of bias. There's explicit bias, that's an overt conscious prejudice. And we can overcome that, we can improve that by increasing education about the complex causes of obesity. That can help us recognize our explicit biases. But implicit bias is an unconscious preference or aversion to certain groups. Our biases can influence our words and our patient interactions. They can reduce the quality of our interactions. Patients may feel physicians are not empathetic. Implicit bias against individuals with high weight is really common in medicine. This is a breakdown of, this is using the Harvard implicit bias test. This test is available free online, and this was comparing a preference for an association of good and bad words with thin, or I'm going to use the term fat here because that's how it's used in the implicit bias test, but we'll talk about not using that word later on. But this is available to you if you'd like to assess your own balance, because as you're aware, then you can try and make conscious choices or conscious awareness to use better words and be more empathetic to try and improve your interaction with patients. You can see that over half of the respondents in this survey had an implicit bias in favor of thin people. So ways to reduce bias and stigma in healthcare. First, be aware of your own bias. Take this test. Second is the environment in your office. So it's really important to think about having appropriately sized office furniture, appropriate capacity medical equipment, things like chairs that are wide enough for your patients or can handle the weight of your larger patients. I had a teenager who was going off to community college, and she told us, this is not a hospital, but this is in her community college. She told us how she went ahead of time to check out the classrooms to figure out if she would fit in the desks. These are not things that we may think about all the time, but if the chairs aren't even accessible, it makes the patient really uncomfortable. They don't feel welcomed. Images in the clinic should be inclusive, non-stigmatizing, and you want to avoid stigmatizing language. As you begin talking about BMI or weight status to children and patients, you want to think about your words. So start by asking permission using open-ended questions. What concerns, if any, do you have about your child's growth and health? Then avoid labeling. So person-first language. This means the patient comes first and the disease is second. The patient is not the disease itself, so a patient with obesity, not the obese patient. And then thinking more about language, think about your word choices. So we discourage words that come across as more stigmatizing, like morbidly obese, obese, fat, large, chubby. Less stigmatizing words are unhealthy weight, gaining too much weight for age, height, health, or using BMI. But keep in mind, even non-stigmatizing language can cause really strong emotional responses in many patients and families. And so it's important to acknowledge and validate those responses while focusing on child health. Okay, so let's think about health consequences of obesity. Again, I am an endocrinologist, so diabetes is my model. We're going to go back to an NHANES survey. This is looking at youth between age 3 and 19 and looking at patients, at individuals classified as either overweight, which is the lightest bar, up to class 3 obesity, which is the darkest bar. And we're going to zoom in on the diabetes-related consequences. So glycated hemoglobin is the hemoglobin A1C. Fasting glucose is fasting glucose. Hemoglobin A1C greater than 5.7 or fasting glucose greater than 100 is dysglycemia, so that will include both prediabetes and diabetes. And you can see that as the degree of obesity increases, the prevalence of elevated hemoglobin A1C and fasting glucose also increases. The highest risk is those in the highest weight category. So let's look at incidence of diabetes in youth. The first graph is type 1. This is from Search for Diabetes in Youth, which is a multi-center study that looks to understand more about diabetes among children and young adults in the United States. So in the first graph, this is age 0 to 19. There's a very slight increase in incidence of type 1 diabetes, but if we look at the second graph, which is type 2 diabetes, this is looking only at age 10 to 19, because type 2 diabetes is pretty rare before age 10 or pretty rare before puberty. I want you to specifically look at the red line, which is the Native Americans, and the black line, which is non-Hispanic blacks. You can see this really dramatic rise in the incidence of type 2 diabetes between 2003 and 2012. And this really mirrors what we saw a few slides back in this rising prevalence of obesity. Even more common, we diagnose prediabetes, though. So patients will have a mildly elevated A1C, but they won't meet the diagnostic criteria of A1C 6.5 or above to diagnose diabetes, or fasting glucose of 126 or higher, oral glucose tolerance test 200 or higher. So what happens to all these kids who have prediabetes? Their A1C is 5.7 to 6.4, or their 2-hour oral glucose tolerance test is 140 to 199. What will happen to them? So this is a study out of Yale. It was done in their obesity clinic, and they had 117 children who underwent a glucose tolerance test. 33 of those children had impaired glucose tolerance. So they had, after a glucose load, they had a higher number than was acceptable, but it was less than 200. So they followed these kids over the course of an average of 20 months, and they saw 45% went back to normal glucose tolerance, 24% progressed to having type 2 diabetes. So a large portion of this population will either normalize their dysglycemia or stay within the prediabetes range. That's encouraging that not everybody's going to get diabetes, at least not in the short term. Let's look at a bigger study. Sorry. So this study is a longitudinal follow-up of pediatric prediabetes by A1C done out of the Denver Health System. This was done as an electronic medical record data extraction between 2008 and 2014, and they classified the low risk or low range prediabetes as A1C 5.7 to 5.9, high range prediabetes as A1C 6.0 to 6.4, and type 2 diabetes was 6.5 to 7.9. And then they looked at what happened to those kids over time. This was not an intervention study. This was just pulling the data out of their EMR. What happened to the A1Cs in these different risk categories? And so in this low risk prediabetes, a significant portion who lost weight and had normalization of their A1C or remained in that low risk prediabetes. Those who gained tend to progress towards the high risk prediabetes or type 2 diabetes. And you can see that same trend in the high risk prediabetes. And type 2, those that had a bigger weight loss had more chance of decreasing their A1C into normal. The final outcome, about 4% of the low risk prediabetes progressed to diabetes, 8% progressed in the high risk prediabetes, and so it gave an annualized incidence of 2.5% new diagnosis of type 2 diabetes in the low risk prediabetes and 5% in the high risk prediabetes. So it's a relatively small annual incidence overall, and if you're in that higher range prediabetes A1C, your risk is higher of progressing, but that risk is lower if the weight goes down. So recognizing that a lot of kids that we screen for prediabetes may progress to meeting criteria for diabetes, let's think about our monitoring steps. This report is from 2020. It does a really nice job outlining screening and treatment pathways for those with prediabetes. For those who have that low risk A1C 5.7 to 5.9 and a normal fasting glucose, they recommend lifestyle change, education on symptoms of diabetes, and repeat screening in 3 to 6 months. In those who have the higher risk, so the A1C 6.0 to 6.4 or impaired fasting glucose, they do recommend that you consider a glucose tolerance test. Some patients will meet criteria for diabetes based on that testing. Still, lifestyle and symptom counseling should be done, but they recommend screening be done every 3 months. Any child who gets diagnosed with diabetes should be referred to a pediatric endocrinologist. Okay, so what about patients who don't have prediabetes, they don't have diabetes, but they have obesity? What is their long-term risk of future diabetes? We're going to go back again to NHANES data. This is a retrospective analysis of diabetes incidence based on weight at age 15 and weight trend over the next 10 years, so at age 25. And you can see the blue line is patients who were never obese. It's the lowest risk of incidence of diabetes. The red line is patients who always had obesity, and it's going to have the highest incidence of diabetes. The green dotted line is gaining obesity over time, gaining weight over time, is going to have a risk similar to stable obese. And while it was only a small portion of patients who normalized their A1C, only about 1% of the population changed from obese to normal BMI over time, that did significantly decrease the incidence of diabetes. That's this yellow line. A similar study was done on Danish men, about 62,000 men who had been in the Copenhagen School Health Record Registry. the Danish Civil Service Registration System, and then a national patient registry to identify diagnosis of diabetes. About 10% of the total population got diagnosed with type 2 diabetes over the course of this study. They excluded individuals who were diagnosed with diabetes if less than age 30 because they didn't want to misclassify type 1 as type 2, but that may have influenced the total number of type 2s who were diagnosed, just because we know that young adults and adolescents can get diabetes. And so in this graph, we're looking instead at hazard ratio instead of incidence. So the individuals who never had obesity had a hazard ratio of 1, so baseline. If they had obesity only in early childhood, only at age 7, the hazard ratio for getting diabetes was very similar to never having obesity. But if they had obesity at age 13 or young adulthood, that risk was higher, and the highest risk was patients who had obesity at age 13 in early adulthood or at all of the ages. That was about 4-time hazard ratio. Now, this study does have a significant limitation. It does not include females because it was using this civil service registry. So we're missing half of our population, but it's still a really nice longitudinal study showing that weight trajectory, both these studies show weight trajectory influences long-term health risk. So can weight loss improve long-term health is our next question. For this, we're going to go to the DPP, or Diabetes Prevention Program, which is a lifestyle intervention that aimed for 7% weight loss. This is in adults. They had one-to-one pairing of a lifestyle coach with the participants, and they went through a 16-session core curriculum that included nutrition, physical activity, behavioral self-management. It was a very frequent contact. These patients had to participate in physical activity at least 150 minutes a week over at least 3 days, and they did allow individualization. There were 3 arms to this trial, so there was placebo, patients treated with metformin, and patients who were treated with the lifestyle intervention. All of these participants had prediabetes. And so what they saw is there was a significant decrease in diabetes risk, particularly with the lifestyle intervention. So if we go, I'm going to go back, you can see that the weight loss occurred in the first 6 months, was maintained fairly well through a year, and then there was some weight regain over time when they were no longer getting this intensive lifestyle intervention. But the incidence of diabetes remained lower in the lifestyle group compared to the placebo group years after the intervention. So at 3 years from the start of the trial, the risk of the incidence of diabetes in the lifestyle group was 58% lower than in the placebo group. But at 10 years, it was still 34% lower, and 15 years, 24% lower. So I think this really nicely shows us that an intervention to improve health in the medium term can have a long-term effect on incidence of complications. So this graphic is from the Pediatric Obesity Guidelines that came out in January, kind of outlining what you can expect or what a model is for the longitudinal non-stigmatizing care that's coordinated, patient-centered, and its treatment across a lifespan. So it's targeting the patient and the family in partnership with the healthcare provider. The ups and downs show you the waxing, waning nature of this disease. It's recommending shared decision-making, culturally competent care, treatment be coordinated in the medical home, and transition planning. We are dealing with the pediatric patients, but these patients are going to become adults, so they're going to need transition to adult care at some point. And then it addresses many of the structural and contextual factors that influence health and treatment. So access to care, biases, obesogenic environments. I didn't talk about adverse child experiences or ACEs, but those are also related to increased risk of obesity, racism, and health inequities. So let's think about an individual patient. How do we go about treating these patients? So first, you want to take a very detailed history, including medical history for comorbidities, obesogenic medications, development, weight history over time, looking at their growth charts, and linear growth history as well, a complete review of systems, a menstrual history where that's relevant, family history. Are there family members affected by obesity? Do family members have comorbidities related to obesity, like diabetes or hypertension? And then thinking about a lifestyle history. So a dietary history I often do as a 24-hour recall, but you can also do frequency, content, where patients eat can have a factor in food choice and how much they eat, so location. What's their sugary drink history, uncontrolled eating or sneaking, emotional eating, all these different factors. And then a physical activity history. Are they participating in structured activity, unstructured activities? Do they have limitations like pain or breathing problems when they are more active? What is their screen time like, and sleep patterns? And on more parts of the initial clinical evaluation. So social history, particularly paying attention to mental health concerns like depression, anxiety, ADHD, but also thinking about peer relationships, disordered eating habits, and what are their support system? Who is purchasing the food? What is the involvement of family and friends? What's the living situation or childcare situation like? So it's pretty common we'll encounter kids whose parents feel like they're doing everything, but they're reliant on the grandparents for childcare, and grandparents and parents are not on the same page as to how and what to feed the kids. Cultural background's relevant, and geographic location as well. On physical exam, anthropometrics are always important. So height, weight, calculating BMI, blood pressure, pay attention that you're using an appropriate cuff size, you'll get a falsely elevated blood pressure. Does the patient have dysmorphic features that may make you think about genetic or syndromic forms of obesity? Do they have stria, acanthosis nigricans as a sign of insulin resistance? So that's shown right here, this darkening, thickening, velvety look on the skin that we'll often see around the neck or axilla. Do they have hirsutism? Thinking about PCOS risk. HENT exam, think about papilledema. They're at risk for pseudotumor cerebri. Do they have large tonsils? Thinking about obstructive sleep apnea. Do they have a goiter? Pubertal staging is relevant. So puberty increases insulin resistance. Adults actually have lower insulin resistance than pubertal children. Also relevant within that pubertal staging is not uncommon for us to get a consult for micropenis, and really the patient just has their prepubertal and they have a large suprapubic fat pad, so it results in more of a buried penis. And then orthopedic obesity can affect gait. It can cause knee issues, pes planus, so flat feet, bowing, cause pain as well. So you've taken your history, you've done your physical exam. It's important to think about what are causes of obesity. Are we missing anything that has a specific targeted treatment? So first, think about endocrine disorders. So Cushing's syndrome would be excess cortisol, hypothyroidism, growth hormone deficiency, or a rare syndrome called Brohad syndrome. In general, endocrine disorders present with poor linear growth. So most of these patients will have a linear growth slowing, and they may have short stature. But endocrine disorders are the cause of obesity in less than 1% of pediatric obesity. The next category is genetic disorders of energy balance. So that's thinking about those hormonal signaling pathways that we saw, the neuroendocrine signaling pathways in the brain. So leptin deficiency, leptin receptor deficiency, POMC mutations, and MC4R mutations. These are associated with early onset, usually less than age 5 obesity, and hyperphagia. These kids are always hungry. They can't stop thinking about food. And then other genetic syndromes, so Prader-Willi, Bardet-Biedl, Alström syndrome, Smith-Magenis. These are all genetic syndromes associated with obesity, often with developmental delays, often short stature. Many of them have polydactyly. Some of them have retinopathy, and most of them have hyperphagia as well. But these are not the most common causes. More common is this multifactorial, not able to identify a single cause of obesity. It is not uncommon that we encounter medications as a contributing factor. And so that needs to be kept in mind when you're thinking about treatment, both of the patient in general and in the treatment of obesity. So medications that increase weight include insulin, glucocorticoids, estrogen, progestin, some anti-seizure medications, and a very common culprit is atypical antipsychotics like risperidone or Abilify. So sometimes you can make changes into medication choices for other purposes to be more weight neutral or negative. So that might mean changing to metformin, GLP-1 receptor agonists, lamotrigine, topiramate, zonisamide, or weight neutral to weight negative from a seizure perspective. Fluoxetine is more weight neutral than some of the other depression medications. Okay, we've assessed causes, we've assessed medications. Now let's think about comorbidities. If you think back to our definition at the beginning, we talked about the biomechanical, so that's like the fat mass disease. It's related to the weight itself. And so that includes things like obstructive sleep apnea, asthma, intracranial hypertension or pseudotumor cerebri, SCFE, Blount's disease, gastroesophageal reflux. Then we have the category of metabolic disease, or you could think of it like sick fat. So this is prediabetes and diabetes, hypertension, dyslipidemia, PCOS, fatty liver disease are those metabolic diseases. And then a final big category, mental health. So there's increased depression, anxiety, bullying, abuse, disordered eating, ADHD. Specifically for bullying, I'm just going to point out this website, stopbullying.gov, which has some nice resources for patients who are being bullied. Because if you ask these kids, many of them will have been picked on at school about their weight. Okay, so now we're going to go back to the guidelines. This is the algorithm for screening, diagnosis, and evaluation treatment of children and adolescents with obesity. And so for patients who have a BMI greater than the 85th percentile, so in the overweight or obese category, it's recommended that everyone get a comprehensive history, behavioral screening, social determinants of health evaluation, physical exam, and diagnostic studies. Blood pressure for all of these patients as well. Both less than and greater than age 10. A fasting lipid panel is recommended for greater than age 10 for both overweight and obesity, and consider for less than age 10 with obesity. And then fasting glucose tolerance tests or A1C, all are considered appropriate screens for diabetes and prediabetes. ALT as a screen for fatty liver disease. These are recommended for obesity greater than age 10. Consider for overweight greater than age 10. If they have abnormals, they'll need repeat or follow-up testing. About 43% of children and adolescents with obesity will have at least one abnormal lipid level. 1 in 5 will have prediabetes if they have obesity. The prevalence in the US of youth with type 2 diabetes is about 1 in 1,000, but that's higher in minorities than non-Hispanic whites, if you remember back to that search for diabetes graphic. Okay, so now we want to begin treating these patients. How do we decide what to do? You have to assess readiness for change, and often motivational interviewing will be used for this. So there are 4 stages. Engage patients by asking open-ended questions, affirmations, non-judgmental graphics, empathetic reflections. Focusing, this lets you provide and then elicit more information. You can help focus what they're interested or think they need most help with using a healthy habits survey. It's sort of like they give themselves a report card on their healthy habits. This is when you use change talk and sustain talk. We'll also often use this ruler strategy for assessing how important they feel it is to make a change, how confident are they to make a change. So 0 is not important at all or not confident at all. 10 is most important or most confident in the world. Often importance is higher than confidence, and you're trying to help them move their confidence up so that they can make changes. Then there's evoking, using value statements, double-sided and amplified reactions, and planning, where your action reflection, you summarize. You can use teach back and SMART goals. We'll talk more about SMART goals. Okay, so as we begin thinking about treatment, motivational interviewing is recommended across the board, all age groups. We're going to talk shortly about intensive health, behavior, and lifestyle treatment. That is really recommended for age 6 and above. It's not really very much data in less than age 6. And then at the end, we'll talk about weight loss pharmacotherapy and bariatric surgery, which are recommended to consider at age 12 or 13 for surgery. So as we begin thinking about a treatment plan, this is a complex plan that includes nutrition, physical activity, behavioral change, and then in many patients may include pharmacotherapy or bariatric surgery discussions. This is another graphic from the guidelines. So this is just showing you all the different components that are part of an intensive health, behavioral, and lifestyle treatment. They changed this name from, we used to often say, intensive lifestyle or behavioral modification or a weight management program, because they felt this new name emphasized the goal of treatment and improved the weight status and reduction of comorbidities. So they recommend a family-based care. It's a partnership with your multidisciplinary team. They recommend that this be made available promptly. So there's not a watch and wait strategy in the current guidelines. We used to sort of talk about, oh, send the patient to an intervention down the road, try sort of talking to them once and seeing them back in a year, but we know that overall most patients continue to gain over time. So if they are ready to seek an intervention, try to make that available for them when you can, as soon as you can. The intervention is going to include health education and skill building, behavior modification and counseling. We'll talk about some of those components in a minute. It may take place in a healthcare setting, but it may also take place in a community-based setting with linking them to their medical home. The dosage is really important. So longitudinal treatment, long-term treatment across 3 to 12 months, so it's going to last quite a while, and it needs at least 26 contact hours. And that 26 contact hours is based on U.S. Preventive Task Force summarization of data showing that interventions that were at least 26 hours had a higher rate of decreasing BMI in pediatric patients than in studies that had a lower intensity intervention. The format can be group, it can be individual, it can be a combination, and most of the data is for face-to-face interventions, but there is some growing evidence for virtual interventions. So you sort of have to work with what's available to you, and we're all working towards making these types of interventions more available overall. So what are the components of an effective intensive health, behavioral, lifestyle treatment? So higher contact time, discussion of healthy eating, and physical activity are included in essentially every intervention. Many of the effective programs include targeting both parents and children. They may talk about stimulus control, goal setting, self-monitoring, problem solving, and they may include supervised physical activity. So in our clinic, we really try and keep messages simple for allowing families to understand the concepts and be able to take away what they need. So we talk a lot about My Plate as a guide for a balanced, healthy diet. We teach them to use their hand as a guide for portion control. And we talk a lot about it's not a diet, it's a healthy lifestyle. So these are not quick fixes. We're aiming for long-term health, not a short-term reduction in weight. Thinking about the stimulus control or managing the food environment, so it's not always possible to kind of overhaul the entire diet in a single step, but you've got to give them education on what they can do and work towards little changes. So instead of a cookie jar sitting on the counter, replace it with a bowl of fruit. Think about using smaller plates. So these is the same amount of food on both plates, but you can see on the smaller plate, it looks like a lot more food. So someone may feel more satisfied because they think they're getting more in the first place. Repackaging high-calorie foods into smaller pre-portioned packages also limits the amount eaten in a single setting. Okay, now SMART goals. This is a really common tool that we use in setting goals for lifestyle change. So it stands for specific, measurable, achievable, realistic, also sometimes called relevant, and timely. So our example, let's say a kid doesn't eat any fruits or vegetables and they drink 3 sodas or juices every day. So let's start by just cutting back. So if they eat none, let's try 1 fruit, 1 vegetable every day. Let's see if we can take sodas from 3 down to 1 a day. And then that time piece. Review in 1 to 2 weeks. That gives them a chance to assess barriers if they're not meeting goals and set new, bigger goals if they're ready. I really talk to them a lot about it's okay to take baby steps as long as we keep moving forward. Okay, so now let's think a little bit about medication. So this is a different version of that neuroendocrine signaling in the brain, where we've labeled some of the medication interactions. So GLP-1s we're going to talk about. These are signaling on the similar neurons to the leptin receptor, so these are going to be anorexigenic. We're going to talk about phentermine signaling on dopaminergic neurons and topiramate signaling on GABAergic neurons. They're anorexigenic. And then we will talk a little bit about signaling through alpha MSH MC4R receptor as a specific type of medication. First, let's talk about GLP-1s. The first GLP-1 that was approved in adolescents is liraglutide. Liraglutide is also known as Victoza or Saxenda. So this slide shows you both adult and adolescent weight data. This is a diabetes medication and then received weight loss approval. So in the adults, what you can see is there's about 7%, 6% differential body weight loss in the adults who were treated with liraglutide, and an increased proportion of adults who received treatment in blue reached greater than 5%, greater than 10%, and greater than 15% body weight loss. Now those thresholds get set because we know as you're approaching that 5 to 10% body weight loss, think back to the diabetes prevention program, that was a 7% body weight loss. It decreased the incidence of diabetes over time. So this is a clinically relevant amount of weight loss. In adolescents, because we're still growing, we look at change in BMI instead of change in weight, because depending on the age of the patient and whether they're done growing, it may still be appropriate to gain some weight. So we use change in BMI. In the adolescent study, the placebo subtracted adolescent change in BMI was minus 4.7% at 56 weeks, so almost 5% at 56 weeks. After 56 weeks, they stopped treatment and weight regain did occur. So this didn't permanently change the weight set point, but it did bring down weight while they were on treatment. The treatment increased the incidence or the portion of participants who reached the greater than 5% and greater than 10% BMI weight loss. And so this got adolescent approval in 2020. Now, semaglutide, you've probably heard more about recently. So semaglutide is marketed as Ozempic for diabetes and as Wegovy for weight loss. This was approved for weight loss in adults in 2021, and the next slide will look at the adolescent data from 2022. You can see we're approaching 15% average body weight loss with semaglutide compared to placebo at 68 weeks on treatment. You can see very high portions of patients treated with semaglutide reaching the 5 and 10% weight loss categories, and almost a third of participants in that study, this is an adult study, reached greater than 20% weight loss in the adult study. In the adolescent study, the study design was essentially the same. Participants, again, were on placebo or semaglutide, and you can see that there was about 15% BMI loss on average in these adolescents treated with semaglutide. 73% reached greater than 5% BMI loss, 62 greater than 10%, half reached greater than 15%, 37% reached greater than 20% weight loss. So a really effective treatment with really substantial weight loss with semaglutide. And so this got approved for adolescent use in December of 22. Who is eligible for these medications? Patients that are 12 and older, weigh at least 60 kilos, have a BMI equivalent to an adult BMI of 30. But it's contraindicated if there's a family history of medullary thyroid carcinoma, because in rats it showed proliferation of C-cell hyperplasia. So a theoretical risk of medullary thyroid carcinoma. It's contraindicated in patients with acute pancreatitis or gallbladder disease. And it is recommended that you evaluate the response to treatment at 12 weeks on the full treatment dose. It takes time to get to the full treatment dose. You start at a low dose and you up titrate to minimize symptoms, side effects. But if 12 weeks on the full dose, you are recommended to discontinue if the BMI loss is less than 1%. These are diabetes drugs, so they do increase insulin biosynthesis, increase beta cell proliferation, they slow gastric emptying, they improve insulin sensitivity, and they decrease appetite. But the GI side effects are the most common reason that we would stop treatment or decrease treatment. They can have nausea and vomiting as pretty common side effects. They can also increase heart rate and increase pancreatitis risk. These are injectable medications, so they're shots. Liraglutide is a daily shot, semaglutide is a weekly shot, and they're relatively expensive medications, so insurance is often a challenge in getting these medications approved. Okay, so phentermine topiramate is our next medication. So this is marketed as Qsymia. This was tried first in adults and more recently in adolescents. It got adolescent approval last year. So in adults, you can see the red is a mid dose and the green is the top dose of the medication compared to the placebo. You can see a bigger reduction, a much larger portion of patients reaching the greater than 10% weight loss. You can see similar in the adolescents, a large reduction in BMI and an increase in the portion of patients reaching greater than 10% and greater than 15% BMI loss. None of the placebo treated patients reach greater than 10% or greater than 15% BMI loss, compared to almost 40% in the top dose reaching greater than 10% on a medication. This is looking at metabolic parameters in the phentermine topiramate change. So this is HDL first and then triglycerides. So you can see HDL went up on treatment. This is blue, mid dose, turquoise, top dose, and triglycerides went down. So this is not statistically significant after you adjust for multiple secondary endpoints, but the magnitude is similar to the adult trials. So who's eligible for this? Again, age 12 plus, BMI greater than the 95th percentile. It's contraindicated in pregnancy, hyperthyroidism, glaucoma, or within 2 weeks of stopping an MAOI. Precautions, so topiramate is embryo or fetal toxicity, so contraindicated in pregnancy. It can increase heart rate, it can increase suicidal behavior and ideation. There's a risk for ophthalmologic adverse reactions, mood and sleep disorders. The topiramate can be associated with cognitive impairment, like a foggy brain or word finding issues, can cause slowing of linear growth. I caution about metabolic acidosis. We do monitor for that when you're on treatment. It can increase your risk of kidney stones, so hydration is really important. Okay, a couple of slides quickly on setmelanotide. So setmelanotide is targeting these genetic forms of obesity. This is a simplified version of that brain signaling pathway. Remember, leptin signals on leptin receptor onto the POMC neurons. POMC neurons secrete a hormone called alpha MSH that signals on the MC4R neurons, and that is anorexigenic. It decreases hunger. If you have mutations in this pathway, you tend to be early onset obesity and hyperphagic. So we can now target this pathway. And so setmelanotide is FDA approved for treatment of POMC and leptin receptor deficiencies, as well as Bardet-Biedl syndrome. This is individual patients. These are rare disorders. You can see at 52 weeks, we're at about 20+% weight loss in the POMC, almost 30% in the leptin receptor, more than 10% weight loss at this range. They did discontinue here. During this withdrawal period, there was some weight regain. So this is FDA approved, but it's for rare genetic forms of obesity. And finally, just a couple of slides about bariatric surgery. So the two primary surgeries are gastric bypass, also known as Roux-en-Y, or gastric sleeve. So a gastric bypass, you take the proximal stomach and you reconnect that about 100 to 150 centimeters down the small intestine. So you're bypassing the stomach and proximal duodenum. In a gastric sleeve, you're taking this stomach and you're making it into more of a tube instead of a large pouch. And so it's a restrictive procedure more than a malabsorptive procedure. A Roux-en-Y is more malabsorptive than a sleeve. This is data from the Labs and Teen Lab study comparing adult patients who underwent gastric bypass to adolescents. So adults are in yellow, adolescents are in blue. You can see pretty similar decrease in weight in both groups, so about a 30% average weight loss for both adults and adolescents. And then these other two graphs are remission of type 2 diabetes and remission of hypertension. The blue is adolescents, and you can see higher remission of diabetes, higher remission of hypertension in adolescents compared to adults who underwent these procedures. Finally, comparing bariatric surgery intervention in diabetes patients compared to patients who had been medically managed. So Teen Labs patients with type 2 diabetes were matched to today's study, which is a large randomized controlled trial of type 2 diabetes in youth. 64 patients from that. They were matched for age, sex, race, and ethnicity. They looked at baseline A1C and then A1C trend over time. Those who had, at baseline, they were fairly similar. Those who had surgery, the darkest color is normalization of A1C, and at 2 years, over 70% had normal A1C, even though they had diabetes at baseline. In the surgery group, in contrast, in the medically managed patients, there had been a rise in this lightest color, those with A1Cs greater than 6.5, so lack of control of their diabetes. So it helps the metabolic outcomes in addition to the weight loss. Who's eligible for weight loss surgery? There's not necessarily a strict age cutoff. Many insurance companies set an age puberty stage cutoff. The guidelines recommend consideration at age 13. BMI greater than 35 with serious comorbidities, or BMI greater than 40 without comorbidities, and participation in a comprehensive lifestyle modification program. We do offer both medication and surgical management through the Healthy Start Clinic in collaboration with our adolescent bariatric surgery team. Shana Eckhouse, shown here, is our primary surgeon at Barnes. Badr Shakshir is our primary surgeon at St. Louis Children's. And so let's circle back to our case. Remember, we met her in 2017 with a new diagnosis of diabetes. By late 2018, she had uncontrolled diabetes with an A1C of 8.2. She had gained 17 kilos from diagnosis. She was still on insulin, both basal and mealtime insulin, as well as metformin, and that was the first time we discussed weight loss surgery. In early 2019, she decided she was pursuing it. She started monthly medical weight loss and behavioral goal setting. At this point, liraglutide was fairly newly approved for diabetes in adolescents. We started her on treatment with liraglutide, metformin, and insulin. Pre-op, by August, she had a weight of 151 kilos. And at the time of surgery, her A1C was 8.1. She underwent gastric sleeve. She was followed up in May of 2021. At that point, she had lost 15% of body weight. Her A1C had improved to 6.7. She was on less than half of the preoperative basal insulin, glargine. So going into surgery, she had been on about 100 units of glargine or Lantus. She was on half or less than that and was no longer on mealtime insulin. She was still on liraglutide. You can see some pretty dramatic weight loss after her surgery, but it wasn't without complication. She did have reflux symptoms. She struggled to get adequate protein. So it's not a simple quick fix. It's a lifetime of treatment, even if you get bariatric surgery. So in summary, there are many factors that contribute to development of obesity. It's recommended you screen for obesity, contributing factors and comorbidities. Behavioral interventions for obesity work better with more contact time, and medications and or surgery should be considered as part of a comprehensive treatment strategy. If you have questions, please feel free to contact me. Here is my email address. Thank you.